Hey, Concord providers. This is Dr. John Jones, Chief Medical Officer for Concord Medical Group. Really looking forward to a great 2025 ahead and the opportunities that lie ahead for us as a group, Concord as a group, and working together with you as providers. Just a few points of emphasis today. We're going to be touching on areas of documentation. Many of these we've touched on before, some will be new. So bear with me as we go through a few documentation points. First, we'll talk about basic documentation. We'll follow that with a discussion of medical decision-making and differential diagnosis and the importance of those statements. Also, independent interpretation of data, the importance of making sure we put our independent interpretations of EKGs and radiology studies on the chart. We'll talk about the use of scores in the emergency department, also critical care documentation, and then an item that we've really not touched on before, the aspect of shared encounters. Those are encounters where both a APP and a physician shares the care of the patient. As we talk about the basics of documentation, we all know that nothing replaces a good history and physical examination. That's the basis of what we do, and performing those and documenting those well are still very, very important. We want to document who gives us the history, what history they gave, and especially if it's someone other than the patient giving the history, was that information different than from what the patient gave us themselves? We want to document an appropriate and relevant review of systems. We want to be careful to avoid contraindications in our documentation. That can come about by the use of templates, which might be pre-selected. For instance, if a patient presents with shortness of breath and your review of systems normal template pulls into the chart and it says no shortness of breath, those two things would contradict themselves. We want to make sure that we clear those things up so that the chart reads clearly and consistently throughout. We want to express our clinical thought processes. That goes all the way and includes the complexity of the problems being addressed, the data that goes into making our medical decision making, and then finally the differential diagnosis that comes that leads us to a final diagnosis. Some questions we might want to ask ourselves as we document: what diagnoses did we entertain based on the patient's presentation? What things did we rule out? Were there any of those conditions that were potentially serious or life-threatening? Did you consult a specialist or discuss the case with another healthcare provider? Maybe when you talked to the hospitalist about an admission, or the radiologist called you with an impression of the radiology study? Did you review old records? Was there an old EKG for comparison? Maybe a recent discharge summary or a recent clinic note? Or did you access the prescription drug monitoring program? All of those things should be included in your documentation when you do them. If you document all of these things along with your clinical thoughts and considerations as part of your medical decision making, you'll be successful in capturing all the elements necessary for a good chart. Also want you to include a differential diagnosis, items which were excluded based on your clinical examination or maybe ruled out based on labs or radiology findings. Again, I cannot stress enough the importance of including a medical decision-making statement and a differential diagnosis on every patient that you see. We do order a lot of tests, and that leads to data which helps us in caring for the patient. If we ordered and reviewed the test, then we need to make sure that we document those things on the chart as well. If we ordered things like EKGs and radiology studies, we always want to look at those ourselves and put our own independent interpretation of those studies on the chart. It's important that we document it just like that. My independent interpretation of the EKG is normal sinus rhythm with a rate of 70 and all of the EKG elements that follows. Or my independent interpretation of the chest x-ray is negative. We may want to follow that with a final read will be made by radiology, but you do make an independent interpretation and you do use that as part of your medical decision making in caring for the patient. Make sure you document that. What test did you consider but not order based on the clinical decision making or additional risk to the patient? There may be tests that you thought about, but then realized that the patient's there may be tests that you considered ordering, but elected not to order those because they were risky to the patient, or later became unnecessary based on the patient's clinical presentation. All of this should be documented as part of the data portion of your chart. Again, I'll reiterate, if you independently interpret a study, an EKG, a radiology study, be sure that you document it using those words, my independent interpretation of the test shows, and then put your interpretation on the chart. Occasionally in emergency medicine, we use different scores to help us determine the risk to a specific patient. Examples of those scores are a heart score, a TIMI score, a PERC score, Wells criteria for PE or DVT. We'll use other scores like GCS, Glasgow Coma Scale, NIH Stroke Scale. We want to make sure that we document the use of those scores as part of our medical decision making. This should be reflected in your chart when you utilize those scores. A very specific area of documentation is critical care. As we talked about this previously, you probably know that there have to be 3 elements present to qualify for critical care. The first, just ask yourself a question. Was there a potentially life or organ-threatening illness or injury? If there was, did you intervene in some way? That's step number 2. And those interventions can come in a variety of mechanisms. Might be a medication, such as Cardizem for AFib with RVR. Maybe a joint reduction in a shoulder dislocation or splinting. Some procedure that you perform to improve the patient's status. And in behavioral health patients, even actions taken to protect themselves from self-harm. So, question 1, was there a potentially life or organ-threatening illness? Yes. Did you intervene in some way? Yes. That brings you to the third question. Did your care of the patient take more than 30 minutes? That includes time to assess the patient, document your findings, make consultation, arrange for further care. If the total of that is more than 30 minutes, and the answer to the first 2 questions were yes, then this patient qualifies as documentation for critical care. When documenting critical care, you want to document the amount of time spent in performing that care, and also to note that that time spent is separate from any time spent on separately billable procedures. So the time that it took you to place a central line or actually intubate the patient does not count in the coding of critical care. Although in those patients, it is likely that more time was spent in practicing critical care and caring for the patient, so the patient would qualify for the critical care designation. Our final topic today is the idea of shared encounters. Now, this will not apply to every Concord provider at every Concord facilities. This is for our facilities where APPs work alongside physicians in tandem at the same time in the same department. When an APP sees a patient, they often consult the physician who they're working with to discuss the treatment plans, to discuss follow-up needs, or to discuss disposition. When this occurs, you can have a shared encounter that occurs when the physician does not actually physically see the patient. When there's adequate discussion between the APP and the physician to discuss the needs of the patient and to develop a treatment plan. It is enough for the physician to help in make or approving the plan of care for the patient and to take responsibility for that management of the patient. Attestation by the physician should include a statement like this: I personally made or approved the management plan as discussed with APP Smith and take responsibility for the patient's management in this case. Additional information you may want to include is, as the physician, if an EKG was done or radiology study was performed, you would want to include your independent interpretation of that study as well. That should be included in the patient's chart. The attestation, which I mentioned earlier, can be included as a separate medical decision-making note, or you may just include it as part of your final attestation at the time of co-signing the APP's chart. The important points of the attestation is that you as the physician were involved in making or approving the management plan and that you're taking responsibility for the patient's management in this case. We've touched on several points of emphasis for documentation. Just to go over those again, the very basics of documentation include a good history and physical. Don't miss that part. Make sure we get that documented well. Always include a medical decision-making statement and differential diagnosis on each and every chart that you produce. If you had EKG studies and radiology studies ordered, make sure you apply your independent interpretation of those tests onto the chart. If you use scores in the emergency department, include those as part of your medical decision making as well. And when the patient meets criteria for critical care, make sure you document that and document it well. In the case where shared encounters occur, make sure the physician documents on the chart that they have been involved in the plan of care and in developing the management plan for the patient and are taking responsibility for the care plan on that particular day. I want to thank you again for your contributions to medicine and to the care of patients everywhere. Thank you for your work done with Concord Medical Group. We greatly appreciate all of the work that you do in taking care of patients. And we look forward again to working with you and moving forward in 2025. Looking forward to a great year ahead. Thank you all for your attention. Hope you have a great day. If you have any questions, my contact information is attached. Thank you. Take care.